Hi, guys. I hope everyone can hear me. I'm doing this remotely. I'd love to be there, but you wouldn't want me there because I have COVID. Um, hey, I'm excited about today's presentation. Let me introduce Dani briefly and let her get started. Dani is an assistant professor over at the School of Social Work. She has a really distinguished academic background. She's currently an assistant professor. She got her PhD at the University of Chicago, did a postdoc at Wash U, and Dani's published widely on mental health service delivery systems. She's gotten external support for her work from the National Institutes of Health for this work, and today she's going to be talking about psychedelic-assisted therapy. Dani, take it away.
Excellent. Ooh, that's loud. Thank you so much, Dr. Beck. And thank you to all of you for being here today and taking your lunch to come and listen. So, as Dr. Beck mentioned, I'm an assistant professor at the School of Social Work. This is my first year, so I'm really kind of an overview of psychedelic assisted therapy. So first, we're going to talk about what is psychedelic-assisted therapy so that we're all on the same baseline. And then from there, I want to give you some of the history of psychedelic-assisted therapy, acknowledging that healing through psychedelics has been used for centuries by indigenous folks. From there, we're going to look at some data, in particular, one of the MAPS randomized controlled trials looking at MDMA. And then we're going to talk about what psychedelic assisted therapy, also known as PAT, you'll see it that way a lot in the literature. What can PAT learn from the field of implementation science? We'll talk about where PAT is headed from here in terms of policy initiatives and some Mizzou initiatives that are happening here that I hope you all will get involved in. And just a quick disclaimer that psychedelic assisted therapy is not a legal treatment at this time in Missouri, with the exception of ketamine. So this is not considered a training. This is just an introduction to the field of psychedelic sciences. So just a little bit about me before I get started. I am a new assistant professor here at our School of Social Work. So we're just down the street at Clark Hall, if you ever want to come by and say hi. I co-lead the Psychedelic Assisted Therapies Learning Community at Wash U. And I'm also an assistant therapist on a clinical trial looking at psilocybin's impact on treatment-resistant depression and the outcomes there. I've also been trained in MDMA-assisted therapy and psilocybin-assisted therapy. So broadly, my research focuses on improving access to mental health services, strengthening the mental health workforce, dissemination, implementation science, and of course, psychedelic assisted therapy. All right, so it is difficult to turn on your TV or to open up the internet and not hear about psychedelics in 2024. It's definitely had a popular resurgence. And in my opinion, a lot of that is due to this book right here by Michael Pollan, How to Change Your Mind. So this book came out in, I think, 2017-ish. And it does a really nice overview of psychedelic assisted therapy. The author, Pollan, also tries some various psychedelics and then talks about his experience in a journalistic format. So if you find yourself interested in this, definitely check it out. There's also an audiobook and a Netflix series now. But you'll also see folks like John Oliver talking about this. We see lots of articles in New York Times, for example, Prince Harry talking about using psychedelics to treat grief, or a pilot who took psychedelic mushrooms and that impacted a flight that he was supposed to be manning. And then on the right-hand side, you can see a photo of Psychedelic Science 2023. This was the largest psychedelic conference held in history with around 10,000 attendees. And so we're really seeing a resurgence of this topic. So what is psychedelic assisted therapy? So psychedelics kind of come in two formats, naturally occurring and synthetic. And so for naturally occurring, we have ayahuasca, DMT, mescaline, ibogaine, and psilocybin. And for synthetic, we have LSD, MDMA, and ketamine. And so we're going to talk a bit more in particular about the differences between the natural and the synthetic, but I want you to just have an overview that this is broadly what we would consider to be psychedelic substances. And then just a quick overview of what the clinical trials for psychedelic studies typically look like. So they're typically diagnosis specific, looking in particular at depression or PTSD, for example. The sessions usually take place in an adapted hospital room or a room in a community mental health center, for example. And importantly, that room is made to feel comfortable and cozy. So there should be good lighting, nice art on the walls, etc. There's usually 1 to 2 therapists who serve as facilitators. So Mary Casamano, you'll see the picture of her on the right. She's actually a social worker, and she is one of the veteran facilitators at Johns Hopkins who's been doing this work for years, decades now. And these facilitators offer a non-directive approach. They offer warmth, acceptance, and presence. But as opposed to something more like CBT that's quite manualized, in psychedelic-assisted therapy, typically the approach is to be more non-directive and allow the participant to guide the therapy. So it's typically done with just one client, but increasingly there's studies looking at psychedelic-assisted therapy in a group format. So these are the basic stages of psychedelic studies. Typically, we start with preparation. This is where the participant is informed of the study, the protocol, rapport building begins to happen, and psychoeducation. And from there, we move into dosing, and that's where the participant would take the psychedelic. And next is integration, and that is the process where the participant works with the facilitator to make meaning of their to provide an overview of the study design, purpose, and expectations, to introduce informed consent and continued assessment of eligibility, to explore relevant cultural backgrounds and any components of the participant's identity that might feel relevant. Again, to provide psychoeducation around the dosing session and answer any questions and anxieties that the participant might have. To discuss possible side effects of the medications, and importantly, to help the participant create intentions for the dosing session. This preparation sessions are also used to give the client some new tools so that they can stay grounded during their dosing session. So for example, teaching different mindfulness and different breathing activities and practicing those. So the dosing sessions, there's typically between 1 to 3 of those, and depending on the protocol, they last between 6 and 8 hours. So that's why you really need a comfortable space for this to occur. So on the right-hand side, you can see a photo of Marcela and Bruce. These are actually 2 of my trainers for my MDMA-assisted therapy training, and they are just like wonderful humans. And so you can see that the participant is laying down. She has eye shades on, that's very common, and earphones so that she can listen to music. And you'll also see that Marcela is holding her hand. So that's something else that happens during preparation is the discussion of therapeutic touch. and whether or not the participant wants to consent to that or not. So they have to make that decision prior to the dosing. So prior to ingesting the medicine, the facilitators will reassess consent. They'll return to the intention that the participant created and discuss that. They'll also encourage the participants to bring a comfort item with them to the dosing session, whether that's a blanket, a pillow, maybe photos of their family, anything that makes them feel comfortable and safe. They're again going to practice one of those grounding or meditation activities that they can use during the dosing and normalizing any anxiety that comes up. So after the session, after the participant is kind of coming out of the psychedelic experience, we ensure that the participant has a support person to drive them home. And we talk to the participant about a plan for self-disclosure, really encouraging them like, hey, maybe you don't want to post this on social media, right? Probably not everyone in your life needs to know about this because we want them to have the opportunity to make meaning of the experience for themselves. So here are some potential experiences that folks have reported during dosing sessions. So many folks report mystical, spiritual, or transpersonal experiences. Some folks report experiencing ego dissolution, or a feeling of a loss of identity or pure awareness with the universe. This can include perceived death or rebirth, connection to or identification with a higher power, or a reorganization of psychological and emotional constructs. Many folks also describe this feeling of ineffability, this feeling that they like just can't describe what they just went through, right? It's really confusing. And then transcendence of space and time. So integration is that final step of the phases. So typically clinical trials have 2 to 3 integration sessions per dosing. So if we have 3 dosing sessions, then it would go dosing, integration, integration, dosing, integration, integration. And the goals of integration are to help the participant to process and make meaning of their psychedelic experience. So we're really trying to give them the tools so that they can integrate their experiences into their real life. We also talk about their impact on their mood, their attitudes, and their relationships. Trying to tell them, like, encourage them, maybe don't make any dramatic shifts in your life right this moment. This is maybe not the moment to divorce your partner, right? Like, let's hold off on any big decisions. And really just exploring how you can apply these different lessons. So again, we're also encouraging the participant to engage in mindfulness and various somatic activities so that they can connect that mind-body connection. So during integration sessions, the participants can use a variety of strategies to integrate the lessons into their lives. For example, establishing new coping strategies, responding holistically to their environment, increasing psychological flexibility. That's a concept from acceptance and commitment therapy. So just important to note that the psychotherapy that's used with psychedelic-assisted therapy varies widely. So the protocols can range from using acceptance and commitment therapy to CBT, to IPT, right? There's lots of different uses. So that is not standardized at this point in the science. Really encouraging participants to invite new connections and new supports into their life, and exploring areas that need further deeper exploration. So this process can involve encountering and healing intergenerational trauma, the support of family and friends, and also encountering challenges when the participant doesn't identify with society's image of them after they've gone through this process. So set and setting, these are terms you will hear a lot if you move into the psychedelic-assisted therapy space. Set is the kind of mindset that the participant comes into the experience with. This is a composed of the participants' values, their own life history, and their experience with their own mental health condition. The participants' expectations for the trial, their motivations, and their desired outcomes also play into their mindset, as well as the participants' intention that they set. So that's why we're really trying to work with them to create an intention that's positive. And this set, the mindset, is really co-created by the facilitators and the participants. So we'll talk about this a little bit later, but folks refer to psychedelics as non-directive amplifiers. And so they're really kind of taking whatever your current mindset and amplifying it. So that's why we're trying to create a consistent mindset in these studies. And then setting, like I mentioned before, we just want to make sure that the space that this is occurring in is comfortable, it's cozy, it has warm lighting. Music is really important in psychedelic-assisted therapy. So there's actually pre-created playlists. You can go on Spotify and look for the Johns Hopkins psychedelic playlist. It's about 8 hours, and it's created in a way where the music matches the tone of the psychedelic experience. So that's pretty cool if you have any interest in exploring that. All right, so now that we have a basic premise of what these studies look like, what the framework is, let's get into the history. Again, I really want to acknowledge that Indigenous folks have been using these healing psychedelics as healing medicines for centuries. So the Mazatec are an indigenous group living in Oaxaca, Mexico, and they have a long history of using psilocybin mushrooms in spiritual and healing ceremonies. So they host mushroom ceremonies in all-night vigils, and they call these baladas, and these are led by a curandera or a curandero. They involve prayer, chanting, and guidance throughout the night. And the psilocybin allows the curandera to diagnose illnesses, communicate with ancestors, and resolve psychological issues during the rituals. So various indigenous tribes have used psychedelics differently, but often in Oaxaca, what would happen is the curandera would be the one who would take the mushrooms, and then they would be kind of sharing their insights with whoever is in the group who came. So as opposed to our current trials, where the participant takes the psychedelic, it's a little bit flipped there. And then after the ceremony, the curandera provides guidance for applying the teachings. So I want to share with you a story of Maria Sabina. We have, right, all of this history of Indigenous folks using these psychedelics, these medicines for healing traditions. How did it get to the Western world? Well, Maria Sabina is a key actor in that story. So Maria Sabina was a healer in her Oaxaca village who used to hold these all-night mushroom ceremonies for healing in her community. Gordon Wasson, he was actually a banker for JP Morgan, who apparently had an adventurous spirit. And he went to Oaxaca and he participated in one of these all-night vigils with Maria Sabina in 1955. And so in 1957, he wrote about his experience in Life magazine. And he also invited Swiss chemist Albert Hofmann to synthesize the mushrooms that Maria Sabina had gave him. And Albert Hofmann identified that psilocybin was the active ingredient. And so next, Albert Hofmann accompanied Wasson back to Oaxaca, and they visited Maria Sabina. And Hoffman provided her the pills, you can see on the right-hand side, that he had created that contained synthetic psilocybin, asking her to do one of her all-night vigils and to give her evaluation if this was the real deal. So Maria agreed to conduct one of her healing ceremonies with the synthetic capsules. And Albert Hoffman wrote this quote afterwards. As we took leave of Maria Sabina and her clan at the crack of dawn, the curandera said that the pills had the same power of the mushrooms, that there was no difference. This was confirmation from the most competent authority that synthetic psilocybin is identical with the natural product. So after Watson published his article in Life in 1957, the mushroom exploded into Western consciousness. And because of her willingness to share the sacred ancestral use of Nino Santos, knowledge of psilocybin began to spread globally. And during the 1960s, thousands of Westerners trekked to Oaxaca seeking to participate in one of these healing ceremonies. This had a really negative impact on Maria Sabina and her village. The enforcement in Mexico thought that Maria was a drug dealer, and so they started really cracking down on her and her village. So Maria's house was burned down, her son was murdered, and she ultimately died in poverty. And so I think that it's really important in all of this work that we're doing with psychedelics that we are acknowledging not only Maria Sabina, but also the indigenous folks who have really led this work for centuries prior to us. So I wanted to share that story with you all. So now we're going to do a quick detour and talk about the creation of synthetic psychedelics. So if you know anything about me, which many of you don't because you're lots of new faces, I love biking. And so if you didn't know, April 19th is known as Bicycle Day. And that is because of this story. So on April 19th, 1943, Albert Hoffman, who we just learned about, right? He was a chemist for Sandoz, and he essentially created LSD, but he didn't know what it was. And so back then, I guess they were just like, let's try this, let's give it a go. So he tries some, he ingests 0.25 milligrams of LSD, and he begins to feel changes in his perception. He begins to feel kind of sick, and he wants to get home, right? He wants to feel safe. So he gets on his bike and he bikes home. But by this point, he's actively having a psychedelic experience. So Albert Hoffman has the first LSD trip while on his bike riding home. So we commemorate that on April 19th. So if you hear Bicycle Day, you know the story now. So MDMA was created in 1912 by German pharma company Merck, but it actually wasn't tested in humans until around 1960. Ketamine, I'm sure many of you are familiar with this. It was synthesized in 1956 by chemists at Park Davis Company and first studied in the 1960s as an anesthetic, which it is still currently used for. So there's a variety of psychotherapeutic approaches that were developed in the use of psychedelics. So the first is the psycholytic model. So this was really popularized in Europe. And the approach here is many low doses of psychedelics paired with talk therapy. The goal here is to loosen the participants' defenses, making therapy more effective. This also allows the participant to engage in non-ordinary states of consciousness while still remaining grounded. The psychedelic model, which is much more popular in the United States and Canada, the approach here is to provide 1 to 2 high-dose sessions where the therapists are non-directive. And the aim here is mystical experiences, ego disillusion, and disrupting cognitive patterns. So you can see on the right-hand side, I have an image of ketamine lozenges. Those can be seen as more aligned with the psycholytic model, whereas a ketamine IV, where a participant is kind of fully dissociating, that's a bit more like the psychedelic model, a high-dose model. So chatting more about the psychedelic model, I want to just introduce you to some of the big players in this. So Dr. Humphrey Osmond, he coined the term psychedelic, which means mind manifesting in 1957. He's also the individual who introduced Huxley, who is the author of The Doors of Perception, to psychedelics. So him and his studies with Dr. Hoffer, they used LSD to treat alcoholism. And in particular, Bill Wilson, who was the co-founder of Alcoholics Anonymous, took LSD himself from Osmond and agreed that it could help many alcoholics. So Dr. Hoffer was one of Dr. Osmond's collaborators. He was a Canadian biochemist and psychiatrist. And in one of his studies, he found a 50% remission rate with LSD and alcoholism. However, this study has not been replicated. And I will say that for many of the studies that were conducted in the 60s, they had pretty impressive findings, but we have not replicated them. So just keep that in mind. So together they pioneered the psychedelic model, which is what you probably noticed earlier, right? In-depth preparation, the use of eye shades, the use of music through headphones, paired with strong therapeutic support. So here's some more of the other important folks, Betty Eisner and Cindy Cohen. They really emphasize the importance of music, as well as the need for two guides or facilitators. And both of them advocated for the use of set and setting as the key component of treatment. And then Dr. Stan Grof, he is a pretty famous person in this space. He also conducted some of the first LSD research, documenting some therapeutic benefits for disorders like alcoholism. He is the person who developed the concept of psychedelics as non-specific amplifiers, which I mentioned earlier. So psychedelics really have the ability to kind of take your mindset and amplify it, right? And so that's why we want folks to come in with a positive mindset of the experience. So then in 1970, when Nixon passed the drug law, he also created holotropic breath work as a way to continue playing with non-ordinary states of consciousness. And he published The Realms of the Human Unconsciousness, which is really important book in this space. Okay, so probably most of you are familiar with psychedelics' role in the 1960s counterculture, but this is really where things began to shift. So Timothy Leary, he was a psychologist at Harvard, and he was doing a variety of research looking at psychedelics. And he and his collaborator, Dr. Richard Alpert, were actually fired by Harvard. And so when they were fired, Timothy Leary in particular, he kind of took this as his explosion into the popular media, and he really began proselytizing psychedelics, right? He's the one who came up with this phrase, turn on, tune in, and drop out. So he was noted by Nixon to be the most dangerous man in America. So he's often someone who we associate with psychedelics. Richard Alpert, after he was fired, he actually went to India and he began practicing meditation, and he really changed his identity to Ram Dass, who you might know him better as. And he wrote Be Here Now. So together they introduced thousands of intellectuals, artists, and college students to psychedelics. And then in 1970, here we have President Nixon signing into law the Controlled Substances Act. So this banned substances like LSD and psilocybin, placing them in the most restrictive Schedule I category. So this effectively ended psychedelic research for over 40 years by blocking access to these compounds and defining them as having no medical use and high abuse potential. So just a note that MDMA, LSD, and psilocybin are still categorized as Schedule Is. But then we begin to see a resurgence in research in psychedelics. So starting around 2006, maybe a little bit earlier, Johns Hopkins does the first study looking at healthy volunteers and psilocybin. And they really get some interesting findings around mystical experiences. And many of their participants report that this is the most impactful experience that they've had in their life. So you can see some of the studies that progress from there, and then the chart on the right that really just shows this explosion of studies that have occurred since 2020. So I'm not going to read this list to you, but these are just some of the disorders that we have seen clinical trials in when looking at psychedelics. Some of the big ones being major depression, treatment-resistant depression, a variety of substance use disorders, and PTSD. So a common thread that we see among these studies is, again, these reports of profound mystical experiences. And then there's a finding that folks are seeing across the studies that the depth of the mystical experience strongly correlates to the persistence of the benefits of the treatment. So many participants in these studies report that their psychedelic experiences are highly meaningful to their lives and beneficial changes in their lives, including improved mood, attitudes, well-being, satisfaction, optimism, and that kind of psychological flexibility that we talked about earlier. And we're also seeing in the follow-up data, these benefits often last for months or years. So just to kind of wrap up this section on the history, acknowledging where some of these elements in clinical trials came from. So for example, the instruction to go inside, right, wearing those eye shades and talking as little as possible, really comes from the Mazatec tradition, as well as bringing meaningful items to the dosing session. Integration comes from Sanderson. And then again, having that comfortable position, loving presence, Mazatec tradition, eye shades from Osmond and Hoffer, and then music, again, from the Mazatec, from the chanting that they did, as well as Betty Eisner. All right, so I wanted to just do a deep dive into just one randomized control trial so that we can look at what does this data look like from these trials? What are some of the strengths and limitations of these studies? And what are the implications? So this is a phase 3 trial that was conducted by MAPS, the Multidisciplinary Association for Psychedelic Studies. And their goal was to evaluate the efficacy and safety of MDMA-assisted therapy versus a placebo with identical psychotherapy provided. And all the participants had moderate to severe PTSD. So there were 13 sites. Let's see what's important here. Yeah, the treatment conditions, again, MDMA versus placebo. They used blind independent assessors and their procedures. So they had 3 preparation sessions, 3 dosing sessions, and they also used integration after each of those dosing sessions. The participants were randomized to receive a split dose of MDMA or a placebo. And what I mean by split dose is that the participant would get an initial dose of MDMA at the beginning of the dosing session. And then about 2 or 3 hours into it, they had the option to have a booster MDMA dose. They didn't have to take it. So the primary outcomes was looking at PTSD reductions, particularly the CAPS-5 measure, and secondary outcomes included looking at functional impairment using the Sheehan Disability Scale. And then you can see information on the sample there. There was 104 participants with moderate to severe PTSD, primarily female, around 34% identified as Black, Asian, American Indian, Native Hawaiian, or Pacific Islander, and 27% as Hispanic or Latino. And around half had prior lifetime use of MDMA. All right, so let's check out some of the findings here. So on the left-hand side, you can see the outcomes of the CAPS, which was measuring PTSD outcomes. So you can see the red line indicates MDMA-assisted therapy. And you can see significant reductions in PTSD scores, not only for the treatment group, but also for the placebo group, right? So I think that that's important to note that there's something going on here with just the psychotherapy element of these trials. In getting to be trained by Marcela and Bruce, who were some of the primary therapists on this trial, I can tell you that they are like master clinicians, right? And so I'm curious what these placebos would look like in the real world. And then on the right-hand side, we have the functional impairment scale. And similarly, you can see significant, statistically significant reductions in impairment, functional impairment, for both groups, but especially for the MDMA group. All right, so these graphs are looking at, on the left-hand side, the placebo, and on the right-hand side, MDMA. And each of these is indicating what their scores are after their dosing session. So you can see after session 1, session 2, and 3. And for the MDMA group, we are seeing really high remission rates. So around 46% of folks who received the MDMA were in remission from their PTSD symptoms. And 71% lost their diagnosis after 3 dosing sessions. So that's like pretty high for PTSD studies. We don't really see other studies that have findings in that regard. So what's going on here, right? Like, what are the mechanisms that's causing this MDMA therapy to presumably be working here? So I like this quote. So MDMA simultaneously induces prosocial feelings and softens responses to emotionally challenging and fearful stimuli, potentially enhancing the ability of individuals with PTSD to benefit from psychotherapy by reducing sensations of fear, threat, and negative emotionality. So they're kind of hypothesizing that MDMA really helps the therapist do their jobs by kind of lowering the participants' walls and helping them to get closer to their fear, their anxieties, so they can confront it. So some of the strengths of the study, it was definitely a rigorous randomized and masking approach with robust tracking of safety issues. They used validated and standardized measures, and they had clear inclusion and exclusion criteria. They had comparison conditions with blinding, and more than any other psychedelic randomized controlled trial, this was actually the most diverse sample that we've seen. And so that's actually a huge problem with these studies in general, is that typically it's a very white sample. So this study in particular was more diverse, so that is a strength. Some of the limitations is that they excluded participants with high suicide risk or comorbid personality disorders. And we just know that's not super real life, right? Our clients come with all sorts of comorbid disorders. So by excluding folks, we're not really getting like a real picture. It was a relatively small sample size at only 104 participants. And the psychotherapy was not clearly operationalized, which again is kind of an issue in all of these studies. I really like this cartoon on the right-hand side. So I'm guessing we're in the placebo group, right? This is a methodological challenge with all of our psychedelic studies, is that it's pretty easy to identify whether or not you've received the psychedelic or a placebo. So that's a methodological challenge that the field is still working through. Okay, so actually, breaking news, the FDA declined to approve MDMA-assisted therapy. And that was actually pretty directly related to that study that I just presented to you, based on the MAPS data. So the FDA wants more research. They want MAPS to conduct an additional phase 3 trial. And some of the reasons for that are that unblinding issue that I just mentioned, right? That it's pretty easy for participants to figure out whether or not they were in the treatment or the control condition. The FDA is also very concerned that it's difficult to disentangle the effect of the psychedelic versus the psychotherapy, right? How do you disentangle those? They also have safety concerns. For example, MAPS did incomplete data collection regarding cardiac safety. They did limited clinical laboratory data collection. And they didn't collect data on any positive effects that might have come from the treatment. For example, euphoria. They didn't collect data on that. But the FDA is concerned that those positive effects could be linked to abuse. So they want them to collect data on that in a future phase 3 trial. And importantly, research misconduct also occurred, I don't think on the phase 3 one that I just presented, but on MAPS phase 2 trial, where some of the facilitators engaged in inappropriate sexual activity with the participants. The participant came out about this after it was already published, yet that study has not been retracted. So there's significant ethical issues that we have to take into account when we're doing this work because participants are in a very vulnerable position, right? So that really needs to be taken into account when we're thinking about FDA approval moving forward. So these are the steps in the translational process. Psychedelic-assisted therapy has more or less passed the stage, and again, it depends on the psychedelic that we're talking about, but it's more or less past the stage of basic science. So now we're in the stage of efficacy trials, right? What I just presented was a phase 3 efficacy trial for MDMA. Psilocybin is currently in its phase 3 trials. So they're collecting that data right now. So once we have that data from the efficacy trials, the next step is going to be effectiveness studies and then implementing it in the real world. Woo! So some colleagues and I, we wanted to think about what is going to happen when and if psychedelic-assisted therapy gets FDA approval. How are we going to translate this pretty complex protocol to, for example, federally qualified health centers where it's difficult to book a room for 30 minutes, let alone 8 hours, right? So we wrote this paper. It's hot off the press. It came out last week. So I'm really excited to talk with you a little bit about it. So we know from implementation science that historically it takes 17 years to move treatment innovations from research into practice. So implementation science is a field that aims to reduce this research to practice gap by understanding and improving the various factors that influence the uptake of these different practices in real world settings. So in this paper, we use a predominant implementation science framework, REAIM, which stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance, to illustrate 5 different areas where implementation science can potentially help psychedelic-assisted therapy in being moved into the real world. So first is reach. So how do we identify and engage with populations who would benefit most from this treatment? So my colleague Heidi Allen, she always says we need to get this to those who need it most first. So how do we do that? So we know that historically marginalized communities are underrepresented in those randomized controlled trials, as I just mentioned. So a good strategy here would be to apply community-based participatory research principles into our research so that we can improve trust and improve recruitment. Just for time purposes, I'm only going to present one item from each of these tables, but feel free to read the others. Also, the current randomized controlled trials, they primarily focus on efficacy outcomes, right? Like safety, tolerability, and efficacy of the treatment. And they're conducted in highly controlled clinical settings that are not reflective of routine practice settings. They have significantly more resources, right? As one example. And so how are we going to kind of fix that when we get into the real world? So implementation science has developed pragmatic hybrid designs to examine the real world effectiveness and implementation of various treatments. So we can use these hybrid designs to measure outcomes, including effectiveness and implementation at the same time, right? So we can understand what is the acceptability of the treatment to folks working in these settings. What's the feasibility of it? What adaptations need to happen to the treatment protocol? So next is adoption. So this is representativeness of the settings and the willingness of the workforce to adopt a new program. So as you have all just heard me discuss, psychedelic-assisted therapy is a pretty complex protocol to implement, right? It requires a lot of resources, space, time, training, supervision, technical assistance, right? And so our behavioral health workforce is already at its wit's end. We already have a major workforce shortage. How are we going to be asking folks to implement this very complex protocol? So we need to be sure that we are intentionally thinking about how we're going to be offering supervision, technical assistance, and support. And in my mind, we need to be also training our workforce while they're in their programs, right? Whether or not it's their MSW program or their counseling program, psychiatry program, let's be giving them some basic tools in psychedelic-assisted therapy, if anything, for harm reduction purposes, right? While they're still in their training programs. And that will ease some of the workforce burden here when this is approved, because there's going to be a huge demand for this treatment and not enough folks who are trained to provide it. So again, PAD, really intensive treatment. It's going to require significant resources. So we need to think about implementation strategies here. Implementation strategies are the tools that help us get the thing into practice faster, the thing here being psychedelic-assisted therapy. So again, this could be education, it can be supervision, audit and feedback. Those are just some examples of implementation strategies we can use. And finally is maintenance. So how do we sustain this program in the long term? So we need organizational level infrastructure to ensure that there's adequate resources. So for example, ensuring that there's a private room available for 8 hours. How do we do that, right? That's a question that we're gonna have to figure out in partnership with these agencies. Okay, so just wrapping up now. So where do we go from here? So this is a paper by some colleagues of mine. They've mapped the policy landscape of psychedelic-assisted therapy. And you can see that the number of bills by psychedelic drug has significantly increased over time. So with psilocybin, for example, which is the top row up there, you can see the number of bills to either decriminalize it or legalize it has significantly increased. And these are the states that are either considering or have enacted psychedelic-assisted therapy bills. Also, Oregon and Colorado have legalized the use of psychedelics for healing purposes. So we do have 2 states that we can look to as examples here. Additionally, Veterans Affairs, the VA, has expressed interest in researching psychedelics as a treatment option for veterans. Congress has issued funding to begin psychedelic-assisted therapy clinical trials. And President Biden recently signed an executive order allowing active duty service members to participate in clinical trials of psychedelic drugs. So I think veterans are definitely a population that have been interested in this treatment and have really been advocates for pushing it forward for legalization. Cool, so now I get to invite you all to our coffee and psychedelic-assisted therapy. So Greg Williams, wait. Yay, so he is an MSW student in our program. Greg and I are gonna be hosting coffee and Pat. So if you wanna join us Tuesday, November 19th at 10 a.m., we're just going to have a real casual get together where we talk about psychedelic assisted therapy, the current state of it, and then how you can get involved in the work at Mizzou. We also have our Psychedelic Assisted Therapy Journal Club. This is the third Thursday of the month during the academic year from 4 to 5. It's held virtually over Zoom. And essentially, we pick one article that someone finds interesting and we talk about it. And so this I found to be a really fun group. So the next one is tomorrow. So my email is there. If you do want to join us, it's super last minute, but you would be welcome to. Just send me an email. Here's some resources that I wanted to direct you all to. So the Microdose newsletter, it is run by Berkeley. It comes out once a week, and it's a great way to stay up to date on the psychedelic literature and policy landscape. They also have a clinical trials map. So if you find that you have a client who's interested in being in a clinical trial, you can look up that map there. I also really wanted to highlight the work of the Fireside Project. They are a completely free support line that offers psychedelic supports. So you can text them or call them. You can give this number to your clients. They're an organization doing stellar work. And then check out some of these podcasts. These are just some of my favorites, but there's many others that exist. These are some of the Library of Pat readings that I definitely recommend that folks check out. Happy to share these slides afterwards if you would like. These are some acknowledgements to some of my collaborators, and thank you to Greg for his help. And that's all I have for you. So thank you all so much for your attention, and I welcome any questions that you have. Yeah, in the back.
Who have also likely had diagnoses that potentially make different use. In your expertise, in your opinion, what do you think is the maybe modifying factor that makes some of these substances therapeutic versus non-therapeutic recreationally? Is it the intention that modifies it? Is it the setting, or like what?
That's such a great question. So for me, I think it's still an empirical question if I'm like talking from a researcher standpoint. What I would say from my opinion is that I think it's the psychotherapy. I think by combining the psychotherapy element with the psychedelic, that is what is creating the mental health and substance use outcomes that we're seeing, is really having that supportive person who's able to guide you through the psychedelic experience and then help you integrate those experiences into your daily practice. So I think that that is the kind of key mechanism there. But we're seeing a lot of clinical trials that are coming about trying to test only the psychedelic, where there is a facilitator in the room, but they're much more there if there's like an emergency, right? They're not doing active psychotherapy. And so I think that we'll be able to see in a few years more clearly what the effect of the psychotherapy is. And that's really what the FDA wants too. So thank you for the question. Yeah.
Done in the studies to separate like the cultural aspects of it, because generally psychedelics come from cultures that don't believe in like Cartesianism as an idea, and it's more like a holistic approach. So, like, how are the expectations tempered, and how they kind of reconcile what's expected from indigenous cultures versus Western?
That's such a great question. I think that it's probably not being handled super intentionally well in the randomized control trials that I've seen. But to the extent that it is, I think it's being handled in what you mentioned with the expectation setting. So trying to understand what the participants' expectations are coming into the trial, and then trying to provide psychoeducation around what are some realistic expectations from the trial. Not only positive, but negative, right? There could be side effects, there could be a bad trip, right? There's a lot of different potential outcomes. So I think it's something we need to work on better as a field. But I think that managing expectations in the preparation sessions is currently how it's being managed. Thank you. Other questions? Yeah.
Thank you. It's exciting to see someone from a different department and be able to kind of be in conversation that way. I read the FDA statement about, especially it seems like they focus on the methodology of that phase 3 trial. What would do you have any inklings about what they could change or any more research around, what methodology could we do different, like maybe a manualized ACT or app therapy, something else more manualized or no?
Yeah.
Kind of gets the spirit of begin with.
It's a great question. So I think people are actively wrestling with that question right now about the blinding and thinking about like what other controls could we use that are a bit more active, right? So potentially using a very small dose of psilocybin as the control, right? So you're still getting like some psychedelic experience, but it is not to the same level. So that's one idea that people have. MAPS in particular, though, they did just announce last week that they do plan to run another phase 3 trial. And so what they plan to do, to my understanding, is fixing a lot of those data collection issues. So collecting data on the positive effects, collecting data on the cardiac outcomes. That I know for sure they're planning to do is better data collection. I don't know for sure how they're planning to change the psychotherapy element, but I do know that there's lots of conversations about ACT. For example, the article we're reading tomorrow in Journal Club is about how do you integrate ACT, acceptance and commitment therapy, into psychedelic-assisted therapy as the modality for the therapy. So folks are starting to think about that, but in my experience, I don't think MAPS will adopt that because they have a pretty strong therapeutic protocol that they follow. So I'm not too sure how that's going to shake out, but I know in lots of other clinical trials, folks are playing around with manualized treatments as the psychotherapy. Does that answer your question? Okay, cool. Yeah.
Because I thought MAPS was like the research subsidy that changed the Lycos.
They did change to Lycos. You're on it. Yes. So MAPS was initially the arm that ran the clinical trials. It was around the time that this phase 3 trial was published, they did change into Lycos, which is much more a pharma company. MAPS still exists, but I think that they now see themselves as much more of like the advocacy arm for psychedelic assisted therapy, and in particular MDMA. But they're going through a bunch of organizational shifts that I don't even know that they're 100% sure yet what MAPS is. But they definitely have a new pharma arm to them. Other questions? I think we have time for maybe one more. I'm a social worker. I can sit in silence. Yeah. It was really high. Yeah, he definitely had a serious trip. You did not miss that. I did not report on that. You can find that information on the protocols online, but it varies based on the psychedelic. And it also varies based on the trial. So there's just lots of variability there. But again, a lot of the trials that we're seeing are looking at high doses, although increasingly there's more studies coming out looking at microdosing. So not a super clear answer to your question, but the information does exist online. All right. I think we're at time. Thank you all so much for coming. Reach out if you have any questions.
Thank you, Dani. We really appreciate it.